My name is Scott Rushing, and I have the privilege of being a gynecologic oncologist in the Portland, Vancouver community. I've been in the area for about 15 years, and today I'd like to talk a little bit about ovarian cancer. In beginning this discussion, oddly enough, I'd like to introduce you to my dad. This is a picture of my dad. You may be able to note from the picture that my dad was full of life. He was a jokester. He had kind of the glasses half full mentality. Oddly enough, this picture was taken when he was 51 years of age, which is exactly how old I am today. Within about a year of this picture being taken, my father unfortunately passed away from lymphoma. And at that time in my career, I just began my residency program, and I was learning to become an obstetrician gynecologist. And due to our family's experience with my father passing away from lymphoma, I made the decision to further specialize in the field of oncology as a gynecologic oncologist. Now, growing up, Dad would often say, "Son, I've got good news and I've got bad news. What do you want first?" And without fail, I always said, "Give me the bad news, and then we'll end on a high note with the good news." So in today's talk, I'd like to start off with the bad news with regards to ovarian cancer. But I'd like to end on a high note in discussing hope and optimism that we have in dealing with this disease. So with regards to the difficult situation in taking care of women who have ovarian cancer. Ovarian cancer is the 10th most common cancer among women in the United States. And despite it being the 10th most common cancer, it is the 5th leading cause of death in women in this country. Only pancreatic cancer is a disease which has a worse prognosis. Ovarian cancer is a very lethal disease. And the major problem with ovarian cancer is we very rarely are able to detect this in an early stage. You can see from this slide that approximately 80% of patients with ovarian cancer are diagnosed at stage 3 or stage 4 disease. And the survival of these patients, or should we say the cure rate of these patients, is between 5 and 15%. There is no screening test with ovarian cancer. We have tried diligently through the years. At a program I trained at University of Kentucky, we looked very carefully at performing yearly ultrasounds, performing a CA-125 in high-risk populations to try and detect an earlier stage cancer. And we have not been successful in saving lives with coming up with a screening test. There is no mammography, there is no pap smear, there is no colonoscopy in diagnosing ovarian cancer at an earlier stage. And this is quite problematic. So we've got a disease that is quite lethal. We have a disease that is very difficult to diagnose in an early stage. But even more concerning is in all the progress that we've experienced in medicine, we assume that a patient diagnosed with any disease today is going to fare better than someone diagnosed 20, 30 years ago. This particular slide demonstrates that whether a woman was diagnosed with ovarian cancer in the 70s or the 80s or the 90s, and this could be extrapolated to today, her chance of being cured is no higher than what it was 30 or 40 years ago. At the end of that woman's life, she will have the same chance of dying of ovarian cancer than someone diagnosed in 1975. And that is very disheartening. Now, there's the liver and onions. Let's get on to the dessert and that which gives us hope and that which gives us optimism in taking care of women with this dreaded disease. A 5-year survival is a metric that we use when we determine that 5 years after a woman has been diagnosed with ovarian cancer at any stage, what is the chance that she will be alive? You can see a very hopeful, optimistic trend in this slide that over the last several decades, women are living longer with ovarian cancer. We attribute this to more aggressive surgery. We have learned that the more aggressive we are in removing the tumor, the longer that patient will live. Furthermore, we have made progress with treatments. Our chemotherapy is better today than it was 30 or 40 years ago. We are now developing targeted chemotherapy that is a personalized form of treatment that addresses the particular variety of ovarian cancer that our patients have. In today's environment, if a woman is diagnosed with ovarian cancer, there's a greater than 50% chance that she will be alive 5 years later. And this is a significant advancement in the treatment of this disease. Now, the next slide is, in my opinion, the most important take-home message from our talk today. The top line demonstrates the incidence, or how many people in a given year will be diagnosed with ovarian cancer. The line below that is the number of deaths in each year in this country for ovarian cancer. You can see that these lines are in parallel. And what this tells us is that over the last 30 or 40 years, fewer women are being diagnosed with ovarian cancer. The incidence is less. The prevalence of this disease is less. And therefore, as fewer women get this disease, fewer women are dying from this disease. Now, let's talk a little bit about, and just may I add, if you look at the percentages of the prevalence and the deaths, this is a decrease of about 35 to 40%, which is very, very optimistic. And I truly believe that this trend will accelerate and it will continue to decline in a very rapid pace. And this is the reason for my optimism. We have learned in the last 3 or 4 years that many cases of ovarian cancer actually begin in the fallopian tube. The FDA sent out a safety warning to all physicians, especially targeting our colleagues, our benign obstetrician and gynecologist, encouraging them and women who have desire for surgical sterilization that they not undergo tying of their tubes or a tubal ligation, but to remove the fallopian tube in its entirety. And the reason is we are learning that many, if not most cases of ovarian cancer actually start in the fallopian tube. And those cancerous cells leave the open end of the fallopian tube and they seed on the ovary. And by removing the fallopian tube, we are seeing significant decreases in the number of women who are getting ovarian cancer and thereafter will be dying of ovarian cancer because we're removing the tube before they ever develop this cancer. However, the most influential reason that women will be dying at a decreased rate is because of the advancements that we've made in understanding the cause and the genetics of ovarian cancer. When I trained 20 years ago, I was taught that 1 in 10 patients had a mutation that could be attributed to developing ovarian cancer. We now understand through advancements and learning more and more about this disease that approximately 17% of patients will have an identifiable mutation. The star of these mutations is a mutation called BRCA1 and BRCA2. We are able to determine which women are at highest likelihood of developing ovarian cancer in their life and are aggressively counseling these patients at the appropriate time in their life to undergo a prophylactic surgery, removing the tubes and ovaries and many times the uterus. It is critical that we encourage our referring providers, your family physician, your OBGYNs to do a very thorough family history in determining if breast and or ovarian cancer runs in the family of their particular patient. Now, this is a family history of someone who many feel is an incredible actress. I don't have a comment on Angelina Jolie's body of work, but I can state that she has made a huge difference in the number of women who have requested testing in this country for the BRCA mutation. This is the family history of Angelina Jolie's family. She lost her mother to breast and ovarian cancer. She lost an aunt to breast cancer and her maternal grandmother to ovarian cancer. In April of 2013, there was a 65% increase in the number of tests done for BRCA, because it was in that month that Mrs. Jolie wrote an editorial in the New York Times describing her prophylactic surgery for a known BRCA mutation that she was found to have. So because of that, she can tell her children that she will never die of ovarian cancer because she has undergone the prophylactic surgeries to remove these organs that are at risk. This is what gives me hope, is understanding the genetics of this cancer and being able to prevent women from ever developing the cancer. If we do the math, there will be 22,500 women this year who will be diagnosed with ovarian cancer. 17% of those women will have a known genetic mutation. If every woman with ovarian cancer is tested, that is in excess of 4,000 women who will be found to have a genetic mutation. Consider the implications if their daughters, if their sisters, if their aunts, if their children are tested. We will be able to determine in advance many women who would have developed this very lethal disease. So my clarion call is to ask your patients about their family history and to encourage those who have been diagnosed with ovarian cancer, fallopian tube cancer, primary peritoneal cancer, or breast cancer to be tested. And I think that this is one of the things that gives me great hope in being able to make a continual decline in the number of women who are dying of this disease. Thank you. For more information, visit CompassOncology.com.